Welcome back to yet another one of our short presentations about Parkinson's. We're doing this as a new venture for Parkinson's Awareness Month for the month of April. Some of you may be aware that April the 11th is actually World Parkinson's Day, and that commemorates the birthday of Dr. James Parkinson. For that reason, and to give absolute deserved accolades to the wonderful scientists who worked in Parkinson's in the past, at present, and going into the future, I thought it would be a good idea if we just did a walk through the history of Parkinson's. For those of you who may not have listened to our other broadcasts, just a little bit of a refresher. Parkinson's is a progressive, usually slowly progressive neurological disorder. And we have known for many years that it is due primarily to a lack of dopamine being produced within the substantia nigra, or the midbrain, of people affected by the condition. So that's all the refresher I'm going to do, because today we're going to concentrate on the history of the discovery of dopamine, of levodopa, and its introduction, and a little bit about going into the present time and into the future. So let's move back to 1817. Although Parkinson's symptoms were described, some suggest in the Bible and some suggest in South American medicine records, we know in our Western world and in the scientific medical evidence-based world that the first beautiful full description of this condition is attributed to Dr. James Parkinson. And in 1817, he wrote the Essay on the Shaking Palsy, which you can see here. This small book, 66 pages in total, describes absolutely beautifully the symptoms, the description of what the patients were experiencing, and James Parkinson's hope going into the future. So in this 66-page essay on the shaking palsy, Dr. James Parkinson described all the symptoms and the experiences of the 6 people that he had observed. Interestingly, 2 were his own patients, as he was a GP in Shoreditch in London, and 4 were people that he observed walking the streets of London. And you know, right coming up to present time, the average GP, so your GP, probably only has a total of 4 to 6 patients with Parkinson's. So when your GP sees you, he does not have that extensive knowledge base that a specialist, a movement disorder specialist, a neurologist, or a geriatrician may have. So James Parkinson, as I said, was a GP in Shoreditch, and he lived in the same home that his father, who was an apothecary, had lived and practiced. And it was due to his past experience as watching his father make medications that James Parkinson gave the description of the pill-rolling tremor to the tremor that he observed in these patients. The 66-page essay describes not only the movement disorder symptoms, the tremor, the slowness of gait, the walking changes, and the balance problems, but he also went into a lot of detail on the non-motor symptoms that bother so many people today. Things like constipation, bladder problems, sleep disturbances. James Parkinson was definitely a man ahead of his time in describing non-motor symptoms. He got one thing wrong, in that he thought everyone with Parkinson's had tremor. And we now know that that is not the case. We know that approximately 30% of people will never experience tremor. James Parkinson was a man, a visionary, and he appealed in the final chapter of the essay of the shaking palsy. He appeals to his colleagues and those who are yet to come to continue to do testing and experiments, basically at that time in 1817, to try and find out the cause of this condition. One of the treatments that he recommended was leeches, which was a very popular treatment for everything at that time. But really, he had no idea what caused this condition or how to manage it. And today, in 2022, we still do not know the true cause of Parkinson's, but we owe a lot to Dr. James Parkinson. Because he got the fact about the tremor wrong, he was quickly taken up in the 1860s by a French neurologist, Charcot. Charcot was very impressed with the essay on the shaking palsy, but he had already identified that not everything that shakes is Parkinson's, and not all Parkinson's shake. So he rectified that slight error. And it was thanks to Charcot that this condition was given its name. He named it Parkinson's disease in honor of the man who first gave it its best description. Nowadays, disease has very negative connotations and is usually associated with something that may be contagious or transmitted, which is not the case in Parkinson's. And for that reason, we here at Parkinson's WA are quite strong in the fact that we like to refer to Parkinson's as Parkinson's or the condition. It basically could be described to some as a syndrome. Nothing much happened, and we didn't know what was the cause of Parkinson's. But in 1910 in London, and I'd like to point out that this is a very worldwide series of discoveries. People in those days, of course, worked in isolation. We didn't have the World Wide Web and we didn't have Google, thankfully. And people were working, plodding along in isolation. But things have a habit of coming together for the good of mankind. So in 1910, dopamine was identified in London by two scientists, Barger and Ewens. They had no idea of its purpose within the body, but they did understand that it lowered blood pressure in animal models. But as I said, no understanding of its role. A few years later, an amino acid, which was later to be identified as levodopa, was identified in the fava bean. But this was declared at the time to be biologically inactive. Now, those of you who have done a little bit of homework yourselves will be aware that the fava bean is still regarded as a source of L-dopa or levodopa. However, in daily living, it would be practically impossible to take in and have absorbed the sufficient amounts of fava bean to reach the sufficient amount of levodopa required to control the symptoms of Parkinson's. So in 1938, the German pharmacologist Holtz discovered decarboxylase. Now, decarboxylase is an enzyme within our body naturally occurring, which technical term or a McLeodism, which gobbles up our levodopa. So nowadays, when you take your Matapar or your Cinemat or your Stalevo, you are actually taking a component that has been manufactured that inhibits or blocks that gobbling up process. So your Cinemat contains the decarboxylase inhibitor, carbidopa. Matapar contains the decarboxylase inhibitor, benzerazide, and Stalevo also contains carbidopa. So in order to get your medication through the gut and past the blood-brain barrier and avoid all that gobbling up process, the scientists have added a decarboxylase inhibitor or blocker to your levodopa. So without that work of Holt's, we would not be able to take in adequate amounts of levodopa, well, in small enough amounts to address your symptoms. So that was a major breakthrough. In mammal tissue, the combination of levodopa and a decarboxylase inhibitor converts levodopa to dopamine. Now, this might sound a bit complicated, and remember, we're doing a history lesson, not a chemistry lesson. But point one is we cannot take dopamine orally into the body and get it to where it needs to go. So levodopa is the component that we use, and we add that decarboxylase inhibitor to it in order to enhance its efficacy and get it through the body past the blood-brain barrier. Now, moving over to Vienna. In 1959, there was a major breakthrough in Vienna, and Dr. Ole Hornikowitz, who passed away only in 2020, identified a lack of dopamine in the brains of people who had lived with Parkinson's during life. In Vienna, he had access to a lot of post-mortem brains, particularly of people who had experienced post-encephalitic Parkinsonism. So he had lots of brains available to study. And it was the first time that a lack of a substance in the brain had been attributed to a medical condition. And interestingly enough, at post-mortem, this lack of dopamine in the substantia nigra and the striatum of the brain is actually visible to the naked eye. That's quite interesting because our wonderful MRIs and all sorts of tests that we do nowadays do not show anything visible in Parkinson's to aid with its diagnosis. But Dr. Hornikowitz was an amazing scientist, and he had a small amount of levodopa, which he generously collaborated with Dr. Berkmeyer, and he gave him his 2 grams of levodopa to trial. And because they had such a small amount, they decided to go for gold and to use it intravenously. So in 1961, there was, and I hesitate to use the word trial, I should say it was an experiment where they injected people who had been affected by a post-viral Parkinsonism or Parkinson's-like condition. And someone had the foresight to video that very event. And I'm sure if you go on YouTube, you'll be able to find it. It's absolutely dramatic. And so the symptoms just were taken away almost immediately. So this was a major breakthrough. This was followed up quite shortly afterwards in 1967 in New York. And for those of you who have watched the movie Awakenings or read the book, that marvelous book by Oliver Sacks, this is the experiment. George Kotzias had heard about this experiment in Vienna and decided to trial the gradual introduction of levodopa in his patients in a psychiatric hospital in New York. And this too resulted in a wonderful relief of symptoms. And it was about this time that my passion in Parkinson's began, or the seed for my passion was sown, because I was in hospital, my first ward in Northern Ireland, when they were also trialing levodopa on a neurological ward. And we saw the relief, and we were told at that time we would have this condition beaten within 5 to 10 years. And here we are, 2022. We still don't know the cause. We still don't have a cure, but we certainly have treatment that far outstrips anything that I first saw in my first years of nursing. And because these trials were actually experiments. Melvin Yahr, a very well-known neurologist, decided to carry out a double-blind study, and that indicated that levodopa was efficacious and definitely had a place in the treatment of Parkinson's. So we must thank these men who worked collaboratively and dedicated their lives, particularly in the case of Dr. Horniewicz, to the study of Parkinson's and improvements in the care and treatment of people with Parkinson's. Levodopa remains the gold standard treatment for people with Parkinson's. And often people will say to me, why haven't we got anything new? Why haven't we moved forward? Well, we have over the years a lot of new medications, which I'm not going into today, and perhaps we'll do each family of drugs individually in further talks. But a lot of newer medications have been introduced and are used. But levodopa, the replacement for dopamine, remains that gold standard. We certainly learned quite quickly that levodopa, while having a wonderful visible and short-term relief, did come with its own side effects, and the fact that it did not stop the progression of the condition, but we need to continue to increase and tweak and modify the medication regimes. So there was a lot of emphasis put on surgery, on brain surgery. And I think it was about the 1930s when, by serendipity, the first deep brain surgery for Parkinson's was discovered. And this was done in one of the Scandinavian countries, where surgeons were going in to remove a clot or rectify a bleed in someone who'd had a stroke, and inadvertently went into the wrong area and managed to stop the tremor, the Parkinson's tremor, by serendipity. They were advised not to further investigate this serendipitous discovery, but the focus on surgery remained. And going right back up to our normal, to our present times, then deep brain stimulation has taken another leap forward. We have moved from surgery, which forms a lesion and irrevocably damages part of the brain in order to achieve a good outcome for the person with Parkinson's. And we've now moved forward to the implantation of electrical software which can stop either the tremor or stop the side effects of dyskinesia and improve the life of people with Parkinson's. And improvements with deep brain stimulation are coming on by leaps and bounds. So since the 1990s, we have many new medications which work post the synapse, medications which work on addressing dyskinesia, medications which work in many, many different ways. The more we discover, the more we are able to target different neurotransmitters in the brain and different areas in the brain. The discovery of the dopamine receptors, D1, 2, 3, 4, and 5, led to the discovery of dopamine agonist drugs. And as I said, we will address all those other medications, perhaps in another talk. In the 1990s, it became very clear that medications alone are not enough to manage Parkinson's. One of the terrific changes that levodopa made was that people had a longer life living with Parkinson's. When I first started my nursing career, the life expectancy pre-levodopa would have been about 7 to 8 to 9 years. Now, Parkinson's people, my longest patient living with Parkinson's was diagnosed at the age of 40 and passed away at the age of 83. So you can see that the longer a person has the condition, then the more likely we are to have other things that become a factor. And that is where non-motor symptoms now play such a large part in the lives of people with Parkinson's. So it was very clear that medication was not the only tool that we needed to have to address this condition. So the introduction of multidisciplinary teams, particularly driven by geriatricians with an interest in Parkinson's, became the norm. And for those of you who go to clinics, you will be very aware of the vital role that the physio, speech pathologist, occupational therapist, dietitian, social worker, and needless to say, your Parkinson's nurse, all have to play. So the multidisciplinary focus is a great adjunct to the work of the neurologist or the specialist with his medications. Having said that people are now living for much, much longer with Parkinson's, and it is more of a slowly progressive condition because of the advent of levodopa and medications, that takes us into the whole new era of device-assisted therapies. And these are currently, there are 3 device-assisted therapies that are available to people who have had long-term Parkinson's or complex Parkinson's, or perhaps needing a lot of medication to get through the day. The 3 device-assisted therapies, which are a whole topic on their own, that we most normally use are deep brain stimulation, which I've touched on slightly, duodopa, which is a gel form of levodopa that is given directly into the duodenum where it gets absorbed, and it's given over by a pump over the full waking day to get absorbed in very small regular amounts that do not have to bypass the slowly emptying stomach or have to run the gamut of all the gobbling up or blocking that might happen. An apomorphine infusion is another device-assisted therapy. Apomorphine is a very old drug, but it cannot be taken orally, and for that reason it is given by either a subcutaneous injection as a rescue therapy, or more usually as a subcutaneous infusion driven by a pump. And like levodopa, that is given during the waking hours, and it takes care of symptoms very, very well. But as I said, the device-assisted therapies is a whole new topic. So we have explored the history of Parkinson's, the first documentation of the signs and symptoms. We have explored the European and American discoveries that resulted in the identification of dopamine and the development of levodopa. We have briefly touched on device-assisted therapies and all the aspects that we now realize are an integral part of the management of Parkinson's. What remains elusive, and what I firmly believe we will one day achieve, is identifying the holy grail of Parkinson's, the cure, or something at least that will stop the progression of the condition. And that remains the goal of many, many scientists all over the world. So have faith and believe, as I do, that we will one day identify that goal. So this is a wonderful opportunity for me to thank all those people who came in the past, who worked so hard, not knowing the ramifications of their work would make them famous forever. And I've often thought about my ideal dinner party. And I would love to sit down with James Parkinson, Charcot, Professor Horniewicz, who all identified Parkinson's, identified the key missing ingredient. Oliver Sacks, who I had the pleasure to meet and will always respect, that wonderful neurologist who documented so clearly in all his cases. He is one of the best qualitative scientists ever to have lived. Melvin and Yar, who identified the scoring or the staging tool that is still used today. To Muhammad Ali, who pinpointed and portrayed Parkinson so beautifully when lighting the flame at the Atlanta Olympic Games, and to Michael J. Fox, who continues to fight against funding issues and fight for the science that will identify the cure for Parkinson's. Thank you.